Good afternoon, ladies and gentlemen. Welcome you in the Heart Master Symposium. My name is Dr. Musa Akbar from Kuwait. I have the honor and privileges to chair and moderate the session together with my colleagues, Professor Guisibi Rosano from United Kingdom, as well as Professor Mustafa Shimir from Saudi Arabia. Welcome both of you to join me this symposium of the Heart Master. This program is sponsored by Servier in collaboration with the Saudi Heart Association, which is accredited for 2 CME points. And also this symposium will be in broadcast in Sheikh Heart Conference at the same time in United Arab Emirates in Dubai. And also it's accredited by the Dubai Authority. And I would like to welcome those participation people from the Sheikh Heart Conference. And this program aims to share the experience on the best practices on the optimizing the anti-anginal and heart failure treatment implementation from the current guidelines. And today's lectures also is focusing on tailoring the angina treatment for personalized medical management with hemodynamic and metabolic approach, focusing on the role of the Trimetazidine. And I ask kindly all the participants to type their question in the QA. We will have the discussion at the end of the second speaker. So I will introduce the first and then followed by the second speaker. And then we will have a discussion for about 20 minutes. And I appreciate if you type your question in the QA so we can share it with our experience, or with our speaker, sorry. So it's given me a great pleasure to introduce our first speaker for this program, Professor Guisibi Rosano. He's a professor of cardiology and consultant cardiologist at the St. George University of London, and he's a president-elect in Heart Failure Association in United Kingdom. We will welcome you, Professor Rosano, for giving the first talk on optimize the anti-anginal treatment from hemodynamic to metabolic. So Professor Rosano, the floor is yours.
Thank you very much, Professor. It's indeed a great pleasure for me to be here today. Unfortunately, I cannot be in presence, and let's hope that next time it will be possible to meet and directly face to face. So what I will do in the next 20 minutes is to discuss the personalized medical management in patients with chronic coronary syndromes and how to implement the chronic coronary syndrome guidelines. Now, we know that the angina is very prevalent and is very prevalent in all populations. We can see that in Asia, in Europe, Latin America, in the Gulf region, you can see that there is a variability, but is around a 5.3 and a 4 person per 100. However, we also have to recognize that symptoms are often undiagnosed and they are unrecognized by the in clinical practice. Now, if we look at this study, is the Cadence study, we can clearly see that in 80% of symptoms in patients with monthly episodes of angina were unrecognized. But what is more worrisome is that more than half of the episodes of angina in patients with weekly episodes of angina were not recognized, and more than 1/3 of the episodes of patients with daily angina were not recognized. So that is very important, because if we look at the importance of angina, we see that angina per se is associated with a significant increase in risk of cardiovascular death and non-fatal MI, or even stroke or MI by itself. And that is even more important than the presence of ischemia only. Of course, when angina is coupled with evidence of ischemia, is even more dangerous in terms of future prognosis. Now, when we discuss about coronary artery disease, we tend to discuss on either or, so either medical therapy or revascularization. But we have to consider that throughout the life of our patients, then we can, medical therapy and revascularizations, they tend to coexist. We can see a patient that comes in for the first time and is immediately revascularized, but then has to go on medical therapy. And then maybe during his life or her life, then we'll need to have other revascularization procedures. On the other hand, we can have patients that present for the first time with angina that is well controlled by medical therapy. Then they get revascularized at some point in their life, but then they will still need medical therapy. So basically, it's not medical therapy alternative of revascularization, but they need to coexist in the same patient. Now, the ESC as guidelines on chronic coronary syndromes have depicted different clinical scenarios in patients with stable angina symptoms, patients with heart failure and left ventricular dysfunction with angina, patients were stabilized after an acute coronary syndromes or after revascularization, and also patients with vasospastic or microvascular angina, or even those patients where that are completely asymptomatic, where coronary artery disease is detected at screening. And regarding the diagnosis, we know that we can span from non-invasive testing, coronary CTA, or invasive angiography. And of course, the choice will depend on the pretest likelihood of the disease, but also on what we have available at that time and in our practice. So that is important, but we have to focus on how we need to diagnose our patients. So, and when they first present, we can either do a non-invasive testing or a coronary CTA, and then immediately start drug therapy. So you see that drug therapy is the cornerstone and is the first approach in all patients with angina. Then only if maximal therapy is not able to control symptoms and patients still continue to have ongoing symptoms, then we can refer for invasive coronary angiography. Of course, it comes without saying that if we detect a very proximal LAD and a left main or proximal disease with from coronary CTA, then we can go immediately to coronary angiography. But then even after the assessment, the revascularization, then drug therapy is always central. Another important point is that it's apart from the drug therapy, we have to consider that patients with ongoing symptoms and with minimal coronary disease or absent coronary artery disease, they may have microvascular angina. Microvascular angina can be very prevalent, and especially in some subgroup of patients. But when we look at the guidelines, also we see that there are the 6 different phenotypes, but I think that we rarely are able to depict patients that we see in clinical practice in these 6 phenotypes. So most of our patients have COPD, peripheral vascular disease, diabetes, venous insufficiency that may limit the use of beta blockers or calcium channel blockers. They can have progressive worsening of left ventricular function or heart failure that will contraindicate the use of many calcium channel blockers. Then we can have patients that after revascularization are stable but have left ventricular dysfunction. We have those patients where there is a coexistence of coronary stenosis with microvascular angina, and a group of patients that is becoming more and more prevalent is that of patients with a myocardial infarction and normal coronary arteries, or those patients with ischemia, normal coronary arteries. So we have a lot of other subgroup of patients that are not covered by the guidelines. They're very prevalent and that often are a challenge for our medical therapy. Now, the guidelines tell us, and this is the same in Europe or in America, that we need to use antiplatelets in order to prevent future cardiovascular events. And also it's advisable in these patients to give proton pump inhibition. Then together with the antiplatelets, we need to use the lipid-lowering drugs in order to prevent future events. And of course, using different targets and according to the different degree of risk. Also, what is important for the Gulf region is the fact that although the guidelines focus mostly on LDL cholesterol, because of the degree of risk factors that you see clustering in the Gulf area, is the non-HDL cholesterol is very important and should be addressed. And then, of course, the ACE inhibitors are the only other drugs that are preventative. Now, we see that the guidelines also suggest that beta blockers are recommended in patients with systolic heart failure. That is the only indication for beta blockers in patients with chronic coronary syndromes where there is a clear evidence of prognostic benefit. But apart from patients with chronic coronary syndromes and heart failure, there's no evidence whatsoever that beta blockers may reduce events. So when we discussed about the chronic stable angina pectoris, then we have different treatment objectives. One is to reduce the symptoms and prevent cardiovascular disease, and also prevent future cardiovascular events. And also we have to consider that the treatment, the optimal treatment, is considered that treatment that controls the symptoms and prevents the events. So optimal lipid-lowering therapy, optimal ACE inhibition, and antiplatelet therapy. But also, in order to reduce angina, those drugs that are effective in reducing symptoms for that specific patient without interfering with the quality and quantity of life. Regarding the medical therapy and the treatment of angina, we see that the guidelines tell us clearly that the medical treatment of patients is often not just one single therapy. Patients require more than one drug, and in order to relieve angina and ischemia. This is a very important point because it already says that we don't have first line and second line therapy, but also is a contradiction to what is said later in the guidelines. So the guidelines say that there's no universal definition of which drug combination is optimal, and that the anti-ischemic drug therapies must be adapted to patients' characteristic and preference. And this depends on the presence of comorbidities, the tolerance to, according to the different patient profile, the drug-to-drug interaction, and also the drug availability in the different centers. So regarding the anti-ischemic therapy, although there is a clear recommendation for the use of short-acting nitrates, so the sublingual nitrates for the immediate relief of angina, there is an indication of first line that is in contradiction to what is said earlier on the fact that we need to use two other drugs. And also another problem in these guidelines is that they initially say that you need to start with more than one drug. Then they go and say first line and second line, then go in first step, second step, and third step with a lot of issues on tolerability. Because if we look at what is recommended by the guidelines and we see what is in the product leaflet of the drugs that are recommended, we can clearly see in the SMPC of atenolol, for example, but of any beta blockers, that they should not be used with diltiazem or verapamil. And also that the interaction with calcium channel blockers with negative chronotropic effect is strongly contraindicated. So we see that their recommendation also contrast within the text, but also there is a contradiction on what is indicated, on what is it is in contraindicated by the SNPC of the drugs. Now, the major changes that we have seen in the guidelines between 2013 and 2019 is the fact that we have Trimetazidine that initially was considered as a 2B, now has become clearly as a 2A, and as the same level of all other anti-anginal medication. Whilst we see that the combination of beta blocker and CCB is 2B. Now, this is based on the clear evidence of different meta-analysis of all the all trials that have been conducted in patients with ischemic heart disease, that there's no difference in the anti-anginal and anti-ischemic effect amongst the different drugs. Now, if we look more specifically at beta blockers, and we look at the systematic reviews of and meta-analysis of beta blockers, we see that beta blockers in patients with chronic coronary syndromes do not reduce events. But also, they may have some contraindications or intolerance according to the presence of comorbidities. Now, comorbidities are very important because they interfere with the diagnostic pathway. They may aggravate antianginal symptoms. They may affect the use of treatments. For example, the fact of we cannot use we can not fully use the beta blockers in patients with asthma or peripheral obstructive arterial disease. And we cannot use with other medications. We cannot use, for example, or we have to have caution in using ranolazine in some subset of patients. Now, therefore, if we go at and look at the guidelines and we try to put together what is suggested as first line, second line, contraindication, and different and stepwise approach, we see that the guidelines also tend to identify other subgroup of patients according to the heart rate, presence of LV dysfunction, and blood pressure. But we see that we have other subgroup of patients that are not completely covered by these guidelines. Now, the other important and very important point is that we have to move away from the classical view of coronary syndromes, where we see a very nice, very focal, or in this case, two focal lesions and epicardial lesions, where we can say we go there, we dilate them, and that it's solved. Because it's not that easy, because the coronary syndromes are due to not just the epicardial stenosis, but also by dynamic obstruction of this incredible reticle of vessels that is the microcirculation. And what often happens in one patient is that we may have an obstruction, say, on one big epicardial vessel, but then an obstruction downstream in other areas. Or we can have a lesion on, in this case, like on the right coronary arteries, and microvascular angina. And then when we treat the vessel, then we have patients still continue to have symptoms despite a good angiographic success because of the underlying microvascular disease. So we have to consider the importance of microvascular disease in determining symptoms in patients with angina. And for this reason, together with Professor Ferrari and others, a couple of years ago, we've proposed a different approach to the treatment of angina, where we have the different phenotypes of patients with myocardial ischemia that are due to not just at the stable plaque or the presence of microvascular angina, but also by the presence of vasospasm, endothelial dysfunction, inflammation, and metabolic dysfunction. This has led us to suggest the presence, the possibility of approaching the therapy of patients with chronic coronary syndromes with according to the different phenotypes, and identifying a core therapy that then should be adapted according to the different phenotypes like peripheral arterial disease, diabetes, chronic kidney disease, the presence of coronary spasm, the presence of COPD. And that led us to come with, for each different phenotype, to give a green, a red, or a white, where green is preferred, the white can be co-administered, and red is absolutely contraindicated. And you can see that then you can basically look at all your phenotypes. You can look at cardiac phenotypes, so high heart rate, low heart rate, normal blood pressure, low ventricular dysfunction, atrial fibrillation, heart failure, or the presence of comorbidities like diabetes, chronic coronary artery disease, COPD, peripheral vascular disease, and so on and so forth. And that enables us to identify very clearly our patient and see which drug are absolutely indicated, which drug are contraindicated. So we can see, for example, how if we take patients with heart failure, we see that we have a clear indication for beta blockers and ivabradine together, and then add trimetazidine as a first step, or nitrate and ranolazine. And that is exactly in keeping to what the guidelines or the ESC guidelines tell us. So the diamond approach basically expands further the guidelines of the European Society of Cardiology, giving a better personalization. And you can see that in this case, for example, if we have patients with atrial fibrillation, there is indication for verapamil, for beta blockers and verapamil with all the contraindications I highlighted earlier, and then the use of trimetazidine in these patients. Or if we have a patient with high heart rate, of course, we need to use beta blockers and ivabradine, and then we can use trimetazidine and or ranolazine. And you can see that this is exactly in line with the guidelines. Now, however, when we discuss about the antianginals, we have to consider that the antianginals are not all the same. We have beta blockers, calcium channel blockers, and nitrates that are vasodilators. And various studies have shown us clearly that if you combine two antianginal medications with hemodynamic mode of action, you don't see any additive antianginal and anti-ischemic effect. It has been clearly proven by the ASIS, TBET, APSIS, and CSER. So basically, if you give our patient is beta blocked, you're not going to see any additive effect from nitrates or via calcium channel blockers. And also, we've looked at the evidence that has been generated over the years in the past 50 years of medical treatment, and we performed this meta-analysis and this systematic review, showing that there was no evidence that there's one drug better than the other to be used in combination. Now, it becomes clear that if our hemodynamic agents do not work in combination, we need to find a different approach. And the different approach is the approach that is given by trimetazidine. Trimetazidine is a completely different antianginal medication because it blocks the beta oxidation. By blocking the beta oxidation, increases the utilization of glucose to enter the Krebs cycle through acetylcoenzyme A. By doing so, increases the production of ATP per mole of oxygen. So even when there is a reduction in blood flow, the switch towards the glucose utilization leads to more production of ATP. That on one hand is more effective in maintaining contractility, is more effective in reducing myocardial ischemia. But since ATP is generated, there is less release of adenosine. That is the primer for angina. So there is a clear effect on angina through the reduction of the spillover of adenosine and reduction of myocardial ischemia and left ventricular dysfunction because of a greater production of ATP. Trimetazidine has been shown to be as effective as a beta blocker and a calcium channel blocker in monotherapy. These are the comparative studies with trimetazidine and with propranolol. And you can see that the increase, the anti-ischemic threshold and the total exercise time were similarly improved by both trimetazidine and propranolol. And the reduction in episodes of angina were similar in patients receiving trimetazidine or a calcium channel blocker. But I think that this is one of the most beautiful examples on the fact that you need to use a different approach to treat angina. So you can clearly see here, these were patients who were receiving background beta blockade, and then they were randomized to receive either trimetazidine or nitrates. You can clearly see here what I said earlier. So when you give a nitrate, in addition to a beta blocker, you don't see any effect on ischemic threshold, no effect on angina. But when you add trimetazidine to a beta blocker, you can clearly see a significant improvement in time to ST segment depression, so in ischemic threshold, and time to angina. So very clear anti-ischemic effect. And so that tells you that if you have a patient receiving already one antianginal hemodynamic agent, then you need to use the trimetazidine. The effect of trimetazidine have been clearly demonstrated in the largest study ever conducted in patients with angina. This was the Vasco study conducted in 1,960 patients with angina, all of them receiving atenolol, and they received on top trimetazidine or placebo, and you can clearly see a very significant effect of trimetazidine in ischemic threshold and exercise time. But also something that was very important in the study was that if you double the dose, then you can see even a greater anti-ischemic effect. This is very important because that tells us that we don't know what is the threshold of efficacy of trimetazidine, and therefore in the difficult patients, we can even double the dose without any problem. Another important lesson that we have with trimetazidine, and that is something that you may know very well from your clinical practice, is that the drug is very effective no matter what is the background therapy. Patients with beta blocker plus calcium channel blockers, beta blockers nitrates, calcium channel blocker, you see that trimetazidine always decrease the number of episodes of angina, but also this reduction is progressive. So you see one effect at 2 weeks, 2 months, and the effect of 6 months are even greater. So you need to give the drug some time to work. Now, another important point was the study that came from the Shimir study that came from Korea, where they looked at at patients with an acute myocardial infarction that were discharged either on trimetazidine or without trimetazidine, and the MACE-free survival probability was much higher and better with trimetazidine compared to control. Then this is another important piece of information that tells us how the benefits of trimetazidine span from patients with very simple, so patients with just angina, to patients who have angina and are not amenable to revascularization. And we are seeing more and more of these patients nowadays. And you can see that in these patients, the adding Trimetazidine was effective in reducing by 40% the episodes of angina, reducing by more than 50% the use of GTN, and improved clearly the quality of life. Another important point is that often our patients with ischemic heart disease have erectile dysfunction. And we know very well that they cannot use the PDE5 inhibitors, so like sildenafil or tadalafil or whatever, but also they cannot use the injection of prostaglandin if they're taking nitrates or if they take a vasodilator. Now, we conducted several years ago this study where we put a 48-hour ACG monitoring in patients with evidence of inducible ischemia. We asked them to have a sexual intercourse during the study, the monitoring period, and they were randomized to receive Trimetazidine plus sildenafil or nitrates. And you can see that when patients take sildenafil in addition to Trimetazidine, they have significant reduction in the episodes of ischemia during sexual activity. So that tells us that if you have patients with erectile dysfunction, we can safely give Trimetazidine. And indeed, in these patients, Trimetazidine has a compelling, clear indication as it is very safe and has a very significant anti-ischemic effect. Trimetazidine is also very effective in patients with diabetes. This is a study we conducted more than 10 years ago, where we took patients with diabetes who were asymptomatic, or they were thought to be well controlled. And we found that on the 48-hour ECG monitoring, most of these patients had episodes of silent ischemia. And those who were randomized to Trimetazidine had a significant reduction in the number of episodes of silent ischemia, and a reduction in the total duration of ischemia during the monitoring period. So that tells us that our patients with diabetes, even if they do not report symptoms, they still have silent ischemia, and therefore it's better to use in all these patients Trimetazidine. Now, more recently, the Trimetazidine has been tested in order to see whether it was possible to extend the indication in patients with after a PCI. And the AT-PCI was conducted it was a large randomized study that was conducted worldwide. Now, I have to say that there was not a clear and compelling reason to do so, because we know that after PCI, beta blockers do not reduce events. We know that ranolazine in patients after PCI failed also to show any benefit in reducing events, and was associated with some increased side effects. But regardless, the AT-PCI was designed, first of all, to assess the safety of Trimetazidine. This was a study that was mandated by the European Medicines Agency to assess the safety of Trimetazidine and also the efficacy of Trimetazidine added to standard guideline medical therapy in patients who had just had a successful PCI for stable angina and STEMI. So basically, the study was to see whether it was possible to extend the indication in patients who are completely asymptomatic for a prognostic benefit. So it is important to understand what was AT-PCI. AT-PCI was a study to assess a new indication for Trimetazidine as a prevention for PCI, after PCI. It was also a study to assess the safety of Trimetazidine on falls and neurological tremor. AT-PCI was not a study to assess the effect of Trimetazidine on angina. and was not a study to assess the effect of trimetazidine or the anti-cardioprotective effect of trimetazidine during PCI, because the study, or revascularization, because the study patients started to receive the drug afterwards. Now, the study, despite showing a trend towards a reduction in cardiovascular death with trimetazidine, did not demonstrate any significant effect in patients who are completely asymptomatic. So the insight that we get from trimetazidine, from the AT-PCI, is that the study was very successful, and there was demonstrated clearly the safety of trimetazidine post-PCI. Of course, it couldn't show a reduction in angina, because these were patients without angina, so you cannot treat for something that is not present. So just to recap what we said in this past half an hour, basically, there is clear evidence that angina with or without ischemia carries an adverse prognosis. Now, we see that the ESC guidelines on chronic coronary syndromes, they focus mostly on intervention and revascularization, and how to treat patients after an intervention and revascularization with secondary preventative measures on how to implement antiplatelets, lipid lowering, and ACE inhibition. Now, they also say that the combination therapy should be implemented for the control of angina and myocardial ischemia in patients with chronic coronary syndromes. But we, as I showed you, the Diamond approach basically expanded further and allows us to use the same recommendations of the guidelines into a better phenotyping of patients that will basically give us the picture of the patient that we have in front of us, and therefore detect and decide on what is the best treatment for that specific patients that necessarily will be completely different from the one that in 15 minutes will walk through your door and with the same symptoms. I showed you that trimetazidine, either alone or in association with beta blockers, confers a greater anti-ischemic effect than beta blockers alone, as an increased tolerability to antianginal medications, has a significant effect on exercise capacity and quality of life, and should be implemented in most patients with ischemic heart disease. I think I'll be happy to take your question later, and I will stop here for the time being. Thank you.
Thank you very much, Professor Rosano, for a very nice, elegant presentation, informative, going throughout the role of trimetazidine in the antianginal and on the hemodynamic and cellular level, and also very nice information you gave us on the insight from the ATP PCI trial that really was very useful and informative. I ask you kindly to stay after the second presentation, so we'll have, sure, more question in regard to your presentation, but thank you very much. Now I have the great pleasure to introduce our second speaker, Professor Mustafa Shimiri, a friend of mine, and he's also a chairman of Cardiac Science Department in College of Medicine, King Saud University Medical City in Kingdom of Saudi Arabia, where he will give us a talk on diabetic angina patient in clinical practice. Before I give him the microphone, I ask kindly to type your question in the QA. At the end of the presentation of Professor Shimiri, we will have a discussion. So thank you very much for your participation, and now the floor is yours, Professor Shimiri, to address your talk.
Thank you very much, Dr. Musa Akbar. Thank you, very good introduction. So I have nothing to disclose for this talk, that except that we are taking some honorarium from so many industrial companies for the talk, or for speaking, or for advisory board. So I'm going about the diabetes in the context of atherosclerosis cardiovascular disease, that the risk factors. And I will give you a case history for management of stable coronary artery patients in diabetics. Then we will discuss some comparison between pharmacological therapy and the intervention, and brief touch on the Trimetazidine and its role in the treatment of coronary artery disease. And then we will conclude. As you know, that already Trimetazidine has been exhaustively talked by the Professor Rosano, and I think we have learned from him a lot about the product. Now, what we want to show you that the major things for the development of atherosclerotic cardiovascular disease is the risk factors. And those risk factors, which is very important, in fact, diabetes, hypertension, dyslipidemia, smoking, and other risk factors, where it starts with the atherosclerotic process started by the presence of fatty streaks, then this fatty streak will take a longer time to develop significant obstruction of the major coronary artery tree. And then that will result in either of the acute coronary syndrome or chronic coronary syndrome with stable coronary artery disease. What I want to say about diabetes, that diabetes, whatever it is, wherever the patient has diabetes, he is not anymore low risk for cardiovascular events. That will be either moderate risk or very high risk. So once you have a diabetic patient, regardless of anything else, that the patient is at very high risk or at a high risk or moderate risk. So the very high risk patients, those with already having a target organ damage from diabetes or associated atherosclerotic cardiovascular disease, those patients who's a high risk without a very high risk, those diabetes for 10 years old, without 10 years duration of diabetes or more, and without any target organ damage. And the younger patient with the diabetes of less than 10 years, and that whether it is type 1 or type 2, that's a moderate risk. So you can observe now that diabetic per se, it puts the person at risk of atherosclerosis, at risk of cardiovascular events, regardless of whether the coexistence of atherosclerosis or no. So this is important because at the end of the day, when you have atherosclerosis with the triggering risk factors, you are going to have atherosclerotic process in the brain and will cause cerebrovascular disease and stroke, or you will have it in the peripheral and it will cause a peripheral artery disease and limb ischemia and amputation, or it will be in the coronary and it will cause a coronary artery disease either in the form of a stable or in the form of unstable acute coronary syndrome of MI or non-STEMI. So that's the process, how the interactions of atherosclerosis and the cardiovascular outcome with the presence of diabetes mellitus. And as we have said, diabetes, if it is there, then you are not anymore low risk. So in our societies, as you know, most of the time the patients with diabetes, they will present late, and you might catch them up only after 10 years of their diabetes development. By that time, they are already very high to very high risk. This is an interesting study that it showed how the myocardial infarction and the stroke will develop in as a hazard ratio in patients with a cohort of a huge number, more than 117. This is an Inertia study. And then you can see that they included all, all the participants, and they looked into their diabetes and the correlation to MI and the stroke relative risk reduction. So in the beginning of the recruitment, if they found somebody already diabetic, he is having a hazard ratio of 5 for the development of a stroke or myocardial infarction. But if the person has, after recruitment, they discover that the patient is diabetes, then he has a 3 or almost 4 hazard ratio risk of relative risk reduction, relative risk for myocardial infarction or stroke. And of course, you can see if there is no diabetes in the beginning, then most probably your hazard ratio is 1. So cardiovascular events is almost always associated with the presence of diabetes, and it will magnify the cardiovascular outcomes because of the presence of diabetes mellitus. And the slides, you can see that it is from more than 350 patients. You can see comparing diabetic with non-diabetes. You can see that the hazard ratio is for the coronary death here, and for the ischemic stroke is so high, up to 2.3 hazard ratio. So it means that comparing diabetic, not diabetes, diabetic patient per se, just having diabetes, he has double the risk of myocardial infarction or stroke. And then diabetic patient is already equivalent to myocardial infarction. This is a patient who has no diabetes, but he has myocardial infarction. And this is a patient who had diabetes, but no myocardial infarction. So they are equal in terms of the outcome. So that's why we say that diabetes is equivalent to myocardial infarction, because they are at the same risk of the outcome or poor outcome. Secondly, that the presence of diabetes is a predictor for frailty in elderly patients. So elderly patient, if he is diabetic, he is more frail compared to the non-diabetic patient. And the frailty, you know, it at work, it play a role in so many aspects of the healthcare and the expenditures of the cost for the healthcare. So that's an important thing, which is important to remember, that diabetes is equivalent to myocardial infarction, even if there is no atherosclerotic cardiovascular disease. This is another study, which is the OSS trial, which showed if you have diabetes with atherosclerosis, your risk of the events rate is too high. The hazard ratio, the relative risk, almost 2.88, almost 3. But if you have either of them, you have diabetes or cardiovascular disease, but not both, they are all equal. So that's again confirming that the diabetes is equivalent to cardiovascular disease. But if you don't have no diabetes, no cardiovascular disease, the event rate, of course, the hazard ratio, the relative risk is 1. So this again emphasizing that the importance of having diabetes, as it is equivalent to cardiovascular event. Now, the other important points is that unfortunately we have the inertia of delaying the management of patients with diabetes, whether for the diabetes or for the other risk factors. And this delay of introducing the cardiovascular intervention by treatment of the risk factors is going to harm the patient by the delay. And that's what we call the inertia of physician or the inertia of clinicians. You can see that the most important factors in diabetic patients, not to treat the diabetes per se to get the hemoglobin A1C, because hemoglobin A1C, it will only reduce per 9%, it will reduce only -3 the events. The events will be, or the ratio will be only 3. But if minus, then you will have a -8.2 reduction if you are treating patient with hypercholesterolemia or for LDL. So 1 millimole of LDL will reduce the risk of events by 8.2. And 4 millimeter blood pressure reduction, it will reduce the event by 12.5, compared to the glucose, which will reduce only by 2.9. So that means it is more worth to get control of the risk factors like the dyslipidemia and hypertension, more than you invest on the treatment of glucose per se. And most of that, patients in our society, as has been said by Professor Rosano, that they are a cluster of risk factors in each patient. And I am sure if you ask yourself how many patients I am seeing, they have only one risk factor. I think that's not existing and negligible. Even if you have one risk factor for somebody, you will find him obese. And that's by itself is enough to indicate that there is a multiple risk factors. So I will introduce to you a case, which is a patient of mine, 55 man who is a smoker and stopped 18 months ago. He's diabetes for 20 years on oral hypoglycemic agent. He's hypertensive for 4 years. He had history of chest pain 18 months earlier, and he was on treatment, but developed worsening of his chest pain, and he came to cardiology clinic. Examination was 140/90 blood pressure, and the heart rate was 76. His weight was 80, and the remaining exam was normal. So he's an average body built with the risk factor of being male, long-standing diabetes more than 10 years, and ex-smoker, hypertension. The risk factor for this patient, and then his investigation revealed that hemoglobin is 13 and the renal profile, liver function test, cardiac markers was normal. So the patient was treated by another hospital with anti-anginal therapy, but unfortunately he continued to have the chest pain, and he came to my clinic. The time I have done his ECG, you can appreciate that he had this lead ECG. His heart rate is around 76, but still there is a room to reduce the heart rate, and there is diffuse ST segment changes in the anterolateral leads. So having him symptoms still there, and he's having those multiple risk factors, I optimize the medical treatment, but we send him for coronary angiogram. And this is what you can see from the system, that you can see this coronary artery tree. You can appreciate how this is the left anterior descending artery, which is the most important artery for the coronaries. And this is the left circumflex artery with its obtuse marginal branches. You can appreciate that this is a dominant angiogram, left dominant system, because of the BDA coming from the left circumflex. You can see that there is no point where you can think of revascularizing this patient. This is all diffuse from the beginning of the LAD up to the end, and from the beginning of the circ up to all branches of this. So the patient was not amenable for any relieving his symptoms by revascularization. What I want to tell you at this stage, that the medical treatment and the percutaneous revascularization for patients with stable coronary artery disease is nothing to do with vital. They are all for symptoms relief. And it is none of this for the treatment or for prognosis, apart from if you have a proximal LAD disease or left main disease. That's a category where you might change the cardiovascular events and mortality. This patient, he was on beta blocker, bisoprolol 10 milligram, calcium channel blocker, amlodipine 5, nitrate, aspirin, rosuvastatin 10 milligram, lisinopril 10 milligram, and in fact, I added for him trimetazidine. And the patient, he was put on 35 milligram twice a day trimetazidine in addition to this. You can appreciate that the trimetazidine has no hemodynamic consequences, and it can be introduced with any one of the medication. There is no drug-drug interaction with any one of the drugs used in cardiovascular or diabetic arena. So this patient, he went, but after that, he went to another hospital, and in fact, in another country, where he underwent another coronary angiogram, and then they, of course, before doing angiogram, they did a lot of tests, and he spent about 60,000 Saudi riyal, and then he came back again with no changes, but again, continue to have from time to time exertional angina. So having those information, I told him from our side, we have only the medication, and this is the only medication you are going to have, but there we have to maximize the medicine up to controlling the blood pressure, the heart rate, and control the lipid profile in your case. And then if nothing, then we have some other sort of angina relief, like sympathetic denervation or pain management or whatever. And you can observe that this patient is only 55 years. As you know, that most of our patients in the Gulf area, they are dying 10 years earlier compared to the Western country. So you can appreciate that most of the drugs, if they are used in the setting of heart failure, or they are used in the setting of myocardial infarction or acute coronary syndrome, there is a mortality reduction and there is cardiovascular event. But in case of the stable coronary artery disease, they are only for the relief of symptoms. I can challenge you that there is no single drug that can be used in treatment of a stable coronary artery disease has any impact on mortality, whether it is total mortality or cardiovascular mortality. So it is very important to embark on lifestyle modification, improve ischemic symptoms. You might go for the ischemic or myocardial revascularization if it is amenable. We know that prognosis might improve if you have a left main or proximal coronary artery disease to be fixed. But overall, don't forget that to treat the patients overall and to tailor or personalize the treatment for your patient depend on the patient's case. Again, this patient came back after about 24 months, and then he told me that I went to somewhere in a nearby country, and then you can see that they threw a metal in the circumflex. I don't know how this interventional cardiologist thinking. He left all the LAD, he left all the problem in the OM, he left all the diffuse, and then he throws a stent of 2.25 by 15 millimeter drug-eluting stent. He threw it here, and then he said to the patient that you have to stick to the clopidogrel and aspirin for 1 year. The time he came to me, he said, I have been through the another angiogram, and they bought for me the AMA. The AMA means stenting. And you can appreciate that, as we have said, that the stenting, we are stenting him, but we don't know what we are doing. Where the problem or where the pain is coming, the symptom of the angina coming from where? The patient has diffuse overall coronary trees. You are throwing the stent here only for the sake of satisfying yourself or satisfying your patient. This is a crime. So we have to be careful not to send the patient for interventional cardiologist if the patient has no amenable lesions for stenting, or there is no hope from complete revascularization to reverse the symptom of your patients. So here I'm trying to compare for you the treatment with medical therapy and intervention for stable coronary artery disease. In the past, in 2005, 2017, there was a COURAGE and the BARIT 2 diabetics trials, which have shown that there is no evidence there is no difference between revascularization by any means or by medical therapy. So we know by this, all the studies, that there is no difference between the drug therapy and the intervention. So don't rush to the intervention if there is no prognostic lesion the patients will be fixed for. And if the patient has diabetes with those diffuse atherosclerotic process, as you can see, probably better not to touch. And this is the outcome, the survival for coronary artery bypass, survival for PCI, survival for freedom from cardiovascular event. There was no difference between the two in both BARIT trial and in the COURAGE trial. So recently in 2019, the ischemia trials came out where they bought a patient for stable and coronary arteries for revascularization or for angiography and angioplasty or surgery, and patient for medical therapy. Again, it showed that there is no difference between the medical therapy and the intervention. This is yellow by medical therapy and routine invasive therapy by blue. There is no difference. And this is almost, I think so, but I think it is the last chapter in the revascularization process in patients with a stable coronary artery disease who does not have a prognostic lesion like left main or proximal LAD. So the goal of our treatment is just to prevent this by revascularization or by drugs in case of unstable coronary artery disease or myocardial infarction, and then optimize health status by the quality of life, and of course revascularization when it is required, when it is appropriate. So in bottom line, medical therapy relieves symptoms. Medical therapy might prolong life, but it is depend on which patient we are introducing the treatment for him. So just touching on the demand supply mismatching in case of the patients like my patient who had a lot of the underlying coronary artery disease, diffuse disease, this patient, they have a problem with the angina secondary to low oxygenation. There is no enough oxygen. And because there is no enough oxygen, the patient will develop the chest pain as a result of ischemia in the territory of the area of ischemia. So the drug is, as we have said, the drug is acting. All the drugs, they have the similarity between relieving the symptom. And the unique Trimetazidine, it works in the cellular level. And this is where is the interesting metabolic work, where it went work in the cell, similar to most of the modern medicine that people going for genetics and for cellular medicine. So that the mechanism of action of the Trimetazidine is a very interesting mechanism of action. For the first time, metabolic approach, reducing the cardiac symptoms in patients with stable coronary artery disease. Since 2012 up to 2016, the guideline, European and American College of Cardiology, addressing the benefit of Trimetazidine in patients with stable coronary artery disease at a different level of evidence like class. And then recently, as Professor Rosanna showed this slide, 2019 is almost class 2-1, class 2A for the patient who has been on treatment, and they are almost equal to beta blocker and calcium channel blocker and the others. And it is very important to emphasize that this drug is really safe, no drug-drug interaction. And I will tell you from my humble experience, but those patients, we introduced the drugs since 2013 in my hospital, and since then, if we come to stop the medication, we can stop any medication from the patient, but you cannot stop Trimetazidine because the patient will fight for you because he feels that this drug is doing something good. So to conclude, Trimetazidine different from other antianginas because it works at the cardiac cell. It does not alter the hemodynamics, neither the heart rate nor the blood pressure. It has no metabolic side effects like hyperglycemia or hypoglycemia or hypertriglyceridemia. It has been tested in more than 5,000 patients worldwide in 29 trials. It provides a clinical relevant to addition in a benefit of combining with the other medication for treatment of patients with stable coronary artery disease. Here, just I want to show you the mechanism of actions. Normally, the glucose pathway is the usual pathway in the normal situation where it produces the ATP and the energy for the heart to contract. Now, when you have ischemia, the two processes going on at the same time. But this process is speed up, meaning that there is a shift from the glucose pathway to fatty acid pathway. And then in the fatty acid pathway, it is very costly. You need a lot of oxygen to utilize this fatty acid pathway. So what Trimetazidine came to block this pathway and to allow only the glucose pathway, which is a very cheap from the oxygen consumption point of view, to produce good amount of ATP for contractility. So the shift of during the ischemia, both process to produce ATP is there, but the glucose will be slow down and the fatty acid will be speed up, but that will be a very costly in terms of energy consumption. So the drugs come to block this enzymatic pathway from the fatty acid area and then allow only the glucose pathway to go and to bring for us the energy for contractility and for relieving the symptom of the patient. This is where the Trimetazidine block the enzymes in this fatty acid pathway. Again, similarly, just the Trimetazidine block the free fatty acid pathway for production of the ATP from the glucose pathway. And then, as I have said earlier, that we have Trimetazidine has probably more than one mechanism of action, as it is a metabolic process with working at the enzymatic and cellular level. It has a vascular muscle cell proliferation prevention or reduction. It has reduced insulin resistance. It has a deposition increase adiponectin, which is fighting against the deposition of fatty fats, and it has some anti-inflammatory. Fatty acid oxidation, as I have said, it is reduced, oxidative stress reduced, mitochondrial function improved, and vascular endothelial function improved. So that's why in addition to beta blocker, or in addition to that, you might have that chance of increasing the energy of ATP by 33%. And that will relieve your patients from the ischemia in the situation of ischemic heart. As you can see, the beta blocker will reduce the energy demand by reducing the heart rate, but the supply will be increased, the oxygen supply or the energy supply will be increased by trimetazidine. The combination of both is ideal if there is no contraindication for beta blocker. So this is my last slide, and I will conclude that diabetes is a major risk factor for atherosclerotic cardiovascular disease. Diabetic patient is not low risk patient, moderate to high or very high risk. And intervention to control the risk factors are paramount important in this situation of diabetes and in our society where the cluster of the risk factors there. For the first time, trimetazidine is included in the algorithm of risk guideline American as a second line and similar to other drugs like in the combination of beta blocker or in isolation without beta blocker. Ischemic heart disease may result from a number of mechanisms, including atherosclerosis and microvascular and coronary vasospasm and platelet dysfunction. So that's why you have to work in more than one area to control the risk factors and to take care of the vasculature. Addressing the energetic origin of ischemia is a very essential, and I love to see this trimetazidine as a part of our formulary to treat patients whom we have the very difficulty of getting the control their ischemia. However, I have some anecdotal experience of treating some of the different type of ischemia like vasospasm, bridging, and sometimes we have the microvascular disease. We are giving them as well trimetazidine, and we see some clinical response from the patient. Thank you very much, and then I will leave the floor for our chairman, Dr. Musa Akbar.
Thank you very much, Professor Shimir, for a very nice presentation and overview of the role of trimetazidine in especially in diabetic patient with your nice case presentation. So we will open now. We have about 20 minutes for discussion, and I will address the first question to Professor Rosano, and then I will see the opinion and experience of Professor Shimir. Professor Rosano, patient who labeled by a cardiologist interventionist who do the coronary angio, that this patient is a syndrome X, and then with no obstructive lesion, the coronaries, otherwise normal epicardial coronaries, he could not demonstrate a vasospasm during his procedure for reason or another, but he labeled as syndrome X. So does really the trimetazidine has a role in these population?
Yes, I mean, it works in patients with microvascular angina. It works pretty well. What is important is that when we get the label of syndrome X or microvascular angina, if possible, if we can look ourselves at the angiogram, because sometimes you can see the hallmarks of syndrome X and microvascular angina. So the very tortuous vessels or the slow runoff. If you get those patients, those are the patients that will benefit. Yeah. If you see, say, normal smooth vessels with normal flow, I would rather look for other causes because then any other antianginal is not working. But in those with true microvascular angina, or either that we see with the tortuous vessels or slow runoff, or those patients where, say, a provocative test has been performed, then in those patients, trimetazidine is working very well. And what is important is that if they have high heart rate, it is always better in these patients with clean coronary arteries or near normal coronary arteries to avoid beta blockers to reduce the heart rate, because beta blockers can have a detrimental effect on the microvasculature, and they can also induce some vasospasm. So trimetazidine, and if we have to reduce the heart rate, then use the ivabradine to reduce the heart rate.
Dr. Shimir, do you want to comment in syndrome X? Have you used it in your experience?
Thank you very much, Dr. Musa. I'm sure you are opening a very active window in the literatures about microvascular disease. And I think diagnosis of microvascular disease nowadays is very difficult It has to have a special, laboratory, special setup, a special interest in terms of physicians to be able to confirm that we are dealing with this type of microvascular disease rather than the other type. We are all, as you know, that you are one of us as interventional cardiologists, that we are dealing with an epicardial large vessel. If it is affected, we can fix it. But some of our patients with stable coronary artery disease, they come back despite fixing their coronary. They are coming back with the same symptoms, or at least symptoms is still there, but is less than before. We used to tell them that this is maybe the metal causing some irritation for your heart, and then you will improve later on. So in that sense, that I agree that sometimes with this metabolic mechanism it might work, but adding it to difficult patient to respond to the usual treatment, I think it is worth. One of our colleagues having a patient with very difficult to treat vasospasm. She is only 35 years old lady, coming almost every week to the emergency room. We tried with her everything, and then including Ivermectin, Trimetazidine, we did all. We added Trimetazidine, again, some improvement, but still, but this case is different because it's vasospasmatic clearly. For the microvascular disease, thank you for bringing this question. I think it is an area going to flare up in the literatures, and we will be able to know better about it, and then we will find some of our physician who's more interested to work on it. But Professor Rosano, I think he works with this Trimetazidine with Professor Ferrari, and they have more experience in a different type of indication for the Trimetazidine.
Yeah. So back to you, Professor Shimiri. Patient with diffuse vasculopathy, diabetic. You show it very nicely by angio. And diabetic, diffuse vasculopathy with cardiomyopathy, less ejection fraction in 40s, and then he's not amenable to any revascularization. Do you think that the Trimetazidine will help, one, in improving his ejection fraction if he uses it, and in improving the symptoms, especially the ischemia, giving the vasculopathy nature for this vessel?
Yeah, thank you very much. Dr. Musa, you know that because of the multiple, the cellular level, it works at a mitochondrial level, and I have shown the array of effect of Trimetazidine in different level of the vasculatures. I will believe that there will be some improvement, definitely not only in terms of the symptoms, but as well as in terms of utilizing the energy, and probably the recovery of the myocardium. But I think purely, I have been across some of the reports that Trimetazidine improve the ejection fraction in some conditions. But I think that Professor Rosano probably will answer this question in terms of ejection fraction in particular.
Professor Rosano, could you comment? There is some small studies showed that there is an improvement in ejection fraction giving Trimetazidine, I think 3 months or more. There are one of the study I showed, I have seen it in the literature. So in this particular patient that Dr. Shimiri has presented vasculopathy, diabetic, and with low ejection fraction, you believe that the Trimetazidine works in both directions, might improve the ejection fraction and also reduces the amount of recurrent angina in this particular patient?
Yeah, absolutely. I mean, we published now 25 years ago the first study on in patients with dilated diabetic cardiomyopathy, most of which were patients similar to the ones we've seen during the case. So, and we've reported that there was a significant improvement in left ventricular function. After our study, several other studies have shown similar effects, and there have been recently 3 meta-analyses of all studies with Trimetazidine clearly showing that there's an improvement in left ventricular function and in exercise capacity in patients with diabetes and cardiovascular disease, but also in patients with diabetes alone. So there's a clear, a very good space. What I always say in these patients, also something that is always useful to add to Trimetazidine is something like fenofibrate. because in your, especially in the Gulf area where the non-HDL cholesterol is very important, and we have data also from, say, the Field and Accord study that showed that in patients like those that we've seen, there is a clear effect on the microvasculature as well. So it's for these patients, I would go for Trimetazidine for the benefit on left ventricular functions and symptoms, but also metabolically, I would optimize them with fenofibrate, because that will probably have an additive effect on microcirculation as well.
Yeah. Dr. Shimiri, or Professor Shimiri, there is a question addressed to you. Thank you for your great talk. As my question, do you recommend Trimetazidine for all diabetic patients, especially if they have the diabetes for more than 20 years and have other comorbidity as well, like hypertension?
Well, thank you very much. The question is very difficult. There is nothing called all in medicine. All diabetic in medicine or all whatever, I don't think it is applicable. As we have said that nowadays, we are in the era of personalized medicine. And personalized medicine means that you have to tailor each of your individual patients differently from the other patients. And then subsequently, if the information came to be in the later on that we have some more evidence, I think we will be able to talk about it. However, I want to make a comment here that after so many years from uses of amiodarone in the Europe, America just not after so many years, maybe 20 years, they start using the amiodarone. Now the Trimetazidine from the North America, some of those graduates, our colleagues, they might not believe on the metabolic effect of this drug, and they don't like to utilize the drug. But if American people that start believing on it and they start having a lot of literature or a lot of research, then they explore the benefits, then it will become like amiodarone, the only antiarrhythmic drug available.
Okay, let's discuss something very hot, which is the patient, a patient undergoing PCI. There is the theory of peri-procedural injury. So, Professor Rosano, really does the Trimetazidine has a role in reducing the peri-procedural injury? That is one. And the second, even after the ATP PCI trial, does have a role in reducing the frequency of recurrent angina post-PCI?
Yeah, let me first say that ATP-PCI was not a study to look at the recurrence of angina, because all patients were completely asymptomatic at baseline, and being patients asymptomatic, it's and also with a very, very small proportion of patients who got angina in the follow-up. I mean, it's actually one cannot comment. I mean, that was not a study for patients with angina post-PCI. And for that patients, as I said, we have evidence that none of the other anti-anginal medications work as well in terms of prognosis. So, but for those patients, for the peri-procedural damage, that is very well documented that Trimetazidine significantly reduce the damage, not just with PCI, but also for those patients who undergo CABG, because those patients who undergo surgery, there is also even a greater benefit. So this is one of the reasons why in all chronic patients that sooner or later will have to undergo revascularization, it's better to have the drug on board and then carry a procedure with the drug on board rather than having it later when they will redevelop symptoms.
Yeah, and this applies also in patients who had post-PCI angina, knowing that the target lesion has been dealt with revascularization, and then he has no other obstructive lesion. Do really and that's also apply for post-CABG, also angina, that the Trimetazidine has a role in decreasing the frequency of angina on those population works very well?
Yeah, absolutely. As I said earlier, and we can have an obstructive lesion, say on the LAD, and then we can have microvascular dysfunction downstream. So if we treat the lesion, then we can have still macrovascular disease that causes angina. Or we may have an obstructive lesion in one vessel, and then microvascular dysfunction on another vessel. And given the benefit of trimetazidine in patients with microvascular angina, then it is in those patients who still have a good angiogram, a good angiographic success, but have angina, then we need to offer a therapy that is effective, and trimetazidine for sure is effective, whilst we should avoid nitrates, because nitrates, dilating the epicardial vessels, they increase the microvascular dysfunction downstream.
Yeah. So this is again question for Professor Shimir. In chronic stable angina, for the stepwise approach, would you recommend beta blocker and then you add nitrate, calcium channel, or you say, no, I will give beta blocker as a hemodynamic, then I will go for cellular giving trimetazidine together rather than a step? Which one you prefer in your practice?
I think this is an important question. I think I will look into the patient's parameters. If the patient's heart rate already 50s, for example, I will not be able to introduce beta blocker, particularly if he's an elderly. Then the first line will be trimetazidine, because you don't have a chance to win when the heart rate is very low already and you can add a beta blocker. So I think it is an individualized, but if they are equal and hemodynamically stable and the heart rate is above 70, then I might start with the beta blocker, because the beta blocker has a measurable outcome, which is the heart rate. Meanwhile, the trimetazidine has no measurable outcome. The only outcome is the symptom relief of the patient. So people will love to see the outcome, whatever the product or they will use, rather than to use something which is not very clear to have the outcome. So I will use beta blocker first in the usual situation with the good heart rate and tolerating, and then I will go after that for trimetazidine if the patient is not yet improved. Or if I am expecting that this is chronic stable angina and he's already been tried with the beta blocker, you can add the trimetazidine.
Yeah. Professor Rossano, what's your experience? Should we add similar to Professor Shimir, or you stepwise approach with other hemodynamics drugs, or you just go with this combination?
No, I would.
Trimetazidine.
Yeah, I think that, I mean, we went ahead in the past years on combination therapy. Now we use combination therapy for hypertension. We use combination therapy for lipid lowering, and we use more than one drug to address them. We use it for antiplatelets. So I think the guidelines clearly say that we can start with more than one drug. And I would rather prefer to use a combination therapy. Even if we have to reduce the heart rate, I mean, there are clearly data that have suggested that if you start ivabradine and beta blockers together, then you get a better reduction in heart rate with less side effects. And therefore try to combine those medications that have the best, success with less side effects. And therefore that allows us to use lower dosage with more drugs. And I tend to use quite low trimetazidine because we became confident over the years. I mean, it's important. It's always important to have confidence in the use and know how to use the drug and when to use it. But I'd rather always try to use more than one drug from the beginning.
Yeah. So perhaps I have last question before we end up. You know, some data showed that trimetazidine has a role in contrast-induced nephropathy, somehow to decrease it in patient going. This is been reproduced from other studies, like the ATPP side? Did they have a look on this and showed really a clear reduction in contrast? Because this is very important, important topic to reduce the contrast-induced nephropathy.
I think that the data on contrast-induced nephropathy are quite strong, and also after the data from contrast-induced nephropathy, trimetazidine is currently tested to also to preserve organs for transplant. So it's that tells you the protective effect. Now the ATPCI didn't look into it because in the ATPCI patients were started trimetazidine after the PCI. So they didn't look into that.
Yeah. In contrast-induced, Dr. Shimir, Professor Shimiri, any comments? Because this is a important things has been observed. The mechanism also was not at that time well clear, but it has cellular protection, and they thought that it's a very important observation that they were observed to reduce contrast-induced nephropathy, especially your patients are all diabetic and they are prone to contrast-induced nephropathy.
Well, that's very important question. As interventionists, they would like to see something to prevent this contrast-induced nephropathy. However, I think up till now there is no good drug to reduce contrast-induced nephropathy except rehydrating the patient before going to the cath lab for the contrast. The trimetazidine, it might have some effect, but I cannot commit myself to the advantage of that. But we need to look into a large study, randomizing some sort of type of patient, and then you will get the information in a better way.
Yeah. So the last message, Professor Rosano, and then we'll conclude. What is the real message from the results of ATP-PCI trial, that still we use the drug, we believe it works in the PCI, but the design of the trial was not to our, to what we expect from it to get these results? Like if we use the drug peri or procedure or pre-procedure, we might get better results than we have used it post-procedure.
No, I think that the message from ATP-PCI is very simple. The drug is very safe, it's extremely safe, and should be used in everyone. Of course, the drug is not working in asymptomatic patients where they do not have angina, so you cannot treat something that is not there. The study was poorly designed. It was well designed for the safety, and it clearly showed the safety, but it was poorly designed for the outcome, because you cannot look at angina in patients who are asymptomatic. So the message is that for peri-procedural damage, the trimetazidine is effective, and then it should be used according to its indication, that is the treatment of angina or ischemia in patients with all forms of coronary artery disease.
I apologize. I was going. Yes, please, Professor.
I want just to comment about this. I think you open a very important question, because we know the safety and the efficacy and the stable angina for the trimetazidine. Trying to put it for the post-stented or post-PCI patients just to see the safety in this group, probably that's by the idea by itself is not very attractive. And then, as you have said that clearly, there was an editorial of criticizing the poor selection, the poor pathway, and the poor design for the study, because there was no angina. So there is nothing to measure. The safety measure we know from the previous study that is very safe, but there is no outcome measure to make from these ATPs. And then people thought that, as you have said, that if it would have been done pre-procedural or comparing it before surgery, it might have some impact. But if the ideal things would have been those patients with the angina post PCI, then that will be a great idea to look into the results of the trimetazidine in those cases.
Before I conclude, I saw last question, then I will conclude, because I cannot ignore it. It's addressed to you, Professor Rosano. And do there any studies show the effect of trimetazidine on the reducing the improvement in exercise stress tests like treadmill in a chronic stable angina? Do we have? And I show yes, but what is the effect on the treadmill test on patient having chronic stable angina, giving the treatment of trimetazidine on them?
Yeah, I think that the data are pretty clear. I mean, all the data I showed you earlier on the anti-ischemic effects were all studies conducted during exercise using our exercise test. More recently, the European Medicines Agency, when they renewed the license for trimetazidine, they looked at 27 randomized clinical trials of trimetazidine, either against placebo or against beta blockers or calcium channel blockers, showing that in all cases, there was a significant improvement in ischemic threshold, ST segment depression, and exercise capacity. So there is a wealth of data on these effects.
Yeah. Well, I would like to come in conclusion. We are on time, maybe 1 minute behind, but thank you for all the participants. We have reached almost 270 participants. Thank you for all of them being with us. And I would like to thank my speaker, Professor Rosano from United Kingdom. Thank you very much for your presentation and a very nice discussion. And Professor Shimir, thank you very much for your presentation and the case that presented and your fruitful discussion. You are from Saudi Arabia, Rosano from United Kingdom. And I have received a lot of questions about this is a scientific meeting that is a CME credited. You can contact the organizer to claim your CME. These to answer all the questions given to me. This is a CME accredited by Saudi Heart Association, by the Dubai Authority, and by also KIMS, Kuwait Institute Medical Specialization. So you will have one or another to claim your certificate. Thank you very much for both of you. I enjoyed the discussion and presentation, and thank you for Servier for sponsoring this. And we hope to see you in the future with another topic in the similar era. So thank you very much, and have a nice day.